So thanks everyone for joining us today. My name is Jenny Hornick and I'm the Digital Marketing Coordinator here at JMIR Publications. And I'm very excited to welcome you to today's webinar, which is part of our JMIR Mental Health series in collaboration with the Society of Digital Psychiatry. So today's topic is balancing innovation and risks with large language models. And I'll pass things on to Dr. John Torous shortly to introduce today's guest. But before I do, we'll just go over a couple of housekeeping items. So firstly, please note that all of your microphones will be muted during the webinar. However, we do encourage that you engage with the panel by submitting your questions, and you can do this pretty easily by just typing your questions into the Q&A box located at the bottom of your screen, and then there'll be a designated time towards the end to address the questions. Additionally, we also record this event, and it will be shared on our YouTube channel. And additionally, we have a special announcement that we will announce towards the end of the session regarding an event that we have coming up in December. So Dr. John Torous will share more details on that later. And that's all from my end. So without further ado, I'll go ahead and introduce Dr. John Torous. So Dr. Torous is the director of the Digital Psychiatry Division at Beth Israel Deaconess Medical Center, which is an affiliated teaching hospital of Harvard Medical School. He's also the editor-in-chief of JMIR Mental Health. So I will pass things off to you, John, to kick things off.
Thank you, Jenny, and thank you to Dr. Bell for joining. We have a lot to cover. As all of you know, we keep these webinars fairly brief. So I want to quickly introduce Dr. Bell. She's the Director of Consumer and Mental Health at Google. She is formerly the Chief Strategy and Science Officer at Headspace and really helped guide it from a mental health app into a digital mental health platform, Headspace Health. She also was one of the founders of Lantern, not Lyra, which was one of the first hybrid digital mental health models. And as we've talked about in prior webinars, hybrid models are really coming back in fashion. So she was perhaps a decade and a half ahead of all of us in thinking about how to implement digital mental health. She's had many roles. She served as assistant professor at Stanford, but I don't want to take up all her time telling you all the things that Dr. Bell has done. I really want to jump into this new paper, Dr. Bell, that you published in JMIR Mental Health called Opportunities and Risks of Large Language Models in Mental Health. So keyword being opportunities and risks. We'll put the link in the chat for everyone to look. It's free to access. It's such an important paper, and I think we've made it required reading for all of the students in our program because it outlines all the parts of it. So I really want to go through it in some detail, then open up to a little bit of discussion, then we'll take some questions. But to jump right in the paper, you start off saying there's these general purpose large language models, and we'll use examples. As examples, I'll say anything I'm saying or you're saying is our personal opinion. We're not speaking on behalf of our employer. We're not endorsing any single product. But there's some general purpose tools like ChatGPT or OpenAI, and then there's kind of specialized ones like MedPalm. What is the difference between these domain-specific LLMs and these general ones?
It's an important grounding question for us. So the general purpose LLMs are the things that we hear about in the news that we might be using ourselves. So those are large language models that are trained on massive data sets. So we think of like trained on the internet or all publicly available information. And it's important to stress they're language models, but they're also multimodal models. So they're trained on images, videos, text, a variety of different sources. And they're really flexible applications. They can do creative writing. You may have followed our recent news at Google Notebook LM. We can make a podcast. So they're really general knowledge models that have flexible utility, whereas a domain-specific language model, such as what we've changed the name of a few times, is now called MedGemini, but was MedPalm, MedLM, and those are essentially further refined. So they're built on top of one of these broader models. So that's why we call it MedGemini now, as it's based on Gemini, but it is further refined using specific approaches and really using curated data from a specific field. So the MedGemini example is it's trained to answer medical questions and kind of proven to perform at certain benchmarks in terms of its general medical knowledge. So these are what we call domain-specific LLMs, which are fine-tuned, ideally, or drawing from evidence-based knowledge bases.
That makes sense as a separation. And I think in part just because language is so integral to mental health and it's how we learn about our patients, it's how we communicate. There is utility to the general practice LLMs, but we really want to talk about the domain-specific ones as well too. And in the paper, you and your team highlight 3 areas where these LLMs could really have a strong impact. You bring up education. One example is Psi LLM, assessment, mental BERT. I just like mental Roberta as the name of one of those models. MedPalm 2 now, Gemini, and intervention ones like Replica, Test, Sibley. But in this world of education, assessment, and intervention, all important, what do you see kind of as a big opportunity in the education world and some of maybe the limitations?
Yeah, so we and really the one of the reasons we were motivated to put this paper out is because we do feel like there's an incredible opportunity to use this technology in the context of mental health. And we recently had a cohort of nonprofits going through a generative AI accelerator through google.org. One of the participants who's actually working on refugee solutions said, we have a moral imperative to use the best technology on the biggest problems in society. And so one of what we're trying to do around framing education or assessment or intervention is just clarify mental health. There's a lot of problems for us to solve, as we all know. But when we're using a new technology, we also want to step into it in a responsible and gradual way. So I'm hoping we can have a more nuanced and kind of specific perspective regarding education, which is where I would suggest we start as a field, and we'll unpack that in this conversation, certainly unpack it in the paper. There's a lot of low-hanging fruit. There's a lot of relatively lower. So when we think about risk, it's relative risk. There's less risk in the context of education. That doesn't mean it's without risk, but there's also huge benefits. And so I think the benefits really outweigh some of the risks, given that there are great approaches that we can use to mitigate those. So benefits of using it, what I mean by education is we can use LLMs to make mental health information, mental health literacy more widely available. We can provide it in more languages and different levels, kind of reading levels and multiple modalities. We often struggle to drive engagement and personalized learning. And so just like when, my kids are learning math via software from their school, that's tailored to them. It's dynamic. It pushes kind of their abilities and helps kind of, it helps them develop this mastery. We can benefit from those same approaches in promoting learning, so tailoring education to learning styles, cultural background, et cetera. We also talk about stigma. And so LLMs can be fine-tuned to provide accurate and destigmatizing information by offering alternative perspectives and really helping mitigate that. It can be this helpful overlay. As well as just adapting, if I'm a private practice clinician and I want to create some training materials or homework for my patient or working in medical center, I can use an LLM to tailor something to be more relevant for my patient. I can use it to help my students or trainees practice. And actually one of the ways that we've used it with nonprofits that we feel that pretty bullish about, and I can speak for Google on this one, is conversation simulators. So we have built a few different conversation simulators that essentially enables individuals delivering mental health care, whether it's crisis support or a task sharing model, to practice, to role play, and practice things like assessing suicidality, which is hard and people avoid doing. And so being able to practice that without requiring a supervisor to be watching you through a one-way mirror or watching your videotapes or doing it with you live, right? There's just some efficiencies that we can gain, of course, still with human in the loop. Happy to speak to some of the risks as well, but I think there's a lot of benefits.
That's good. I still remember taking my therapy supervision and recording on a tape and mailing it to someone. And I don't consider myself that old, but that's what I had to do in my training.
I had a one-way mirror in my office at Stanford. So I did family therapy. So, that was pretty, but yes, it's, we can change the paradigm now.
And if we think of assessments, I think no one here is saying that a LLM or chatbot is going to make a formal clinical diagnosis, but definitely assessment is complex clinically. And I think there's some opportunities there. Maybe we could quickly expand on kind of what you see are those opportunities. Again, we're not claiming it's making a formal diagnosis. No one has made that claim.
Yes. Well, I think with this one, I think back to when I was in training where I was encouraged to get experience across a full spectrum of mental health. So work in an inpatient unit, work in a variety of different settings, really understand what the range looks like. Because we know as humans, we don't do a great job when it comes to taking things into consideration, like base rates of diagnoses, at doing differential diagnosis. Sometimes biases get in the way, whereas an LLM could be trained to overlay what I'm doing as a clinician and help increase my objectivity, my accuracy, and ideally lead to more accurate. We can also use it in the context of screening, monitoring. We've talked as a field a lot about actually doing measurement-based care, but we know that often does not happen. And there are some very practical ways we could integrate this technology to further facilitate, just supporting therapists and adhering to evidence-based practice. I think those of us that have worked on, treatment development or treatment outcome trials where our sessions, back to what John, you were saying, we're videotaping it, we're rated for adherence, we're getting supervision. We know that's not typical in practice. And so being able to really overlay this technology to help monitor patients, but also help us get better at what we're doing.
Yeah. And then we've quickly covered education, assessment. On the intervention spectrum, I think as at least of today, the FDA has not approved a LLM for mental health. We have chatbots that do different things, but where do you see the role of LLMs in more the intervention? And again, I think no one's saying an LLM is going to replace care, but there's many things we do in treatment that are useful: diet, exercise, sleep. So where do these things fall in the treatment intervention sphere?
Yeah, so I think as anyone will see in our paper, would say, please proceed with caution in defaulting to chatbot in this. So I think there's a lot of utility of LLMs in the context of intervention or treatment without jumping to that step of a chatbot delivering, like a chatbot therapist, for example. So I'd focus on supporting clinicians as one of the primary use cases. So summarizing patient information, providing insights, helping with treatment matching and selection. We already could use machine learning without even needing to use an LLM to facilitate that. So guiding in that process, providing support to better align what we're doing with evidence-based practice. So we've touched on that a little bit around kind of monitoring for adherence to delivering evidence-based treatment. You could imagine if I'm a therapist providing, I could get feedback after my session about something to consider the next time, support supervisors by reviewing videos suggesting additional learning opportunities. So if I've had somebody watch, the LLMs coding my session for adherence to, CBT and say, you might want to practice doing this particular technique with your patient because you're not doing it in exactly the most effective way. Also personalizing interventions in our entire field of digital mental health, right? We've talked about personalization, but we're often developing things still in a fairly static way. And so tailoring to individuals' needs, preferences, cultural background, while keeping the core intervention principles the same. So lots of different things that are quite different than just jumping to chatbot. There are some use cases for chatbots, but definitely not on the treatment side without SAMD clearance.
So it's also what's nice is all these things you said are kind of complementary to what is the standard of care today. We're not talking about a radical transformation, which is hard in healthcare. We're saying these are things that could be used today, and I would argue would have an amazing impact with the tools that we have out there. So we've talked about the risk benefits broadly of these three, and you have a beautiful table one that outlines a lot of these. In the paper, you also note that people need to be cognizant that these may perpetuate inequities, disparities, and stigma. You touched on it, but maybe just to elaborate a little bit more, what is the potential concern there and how can we minimize those risks?
Yes, so the risk of perpetuating inequities and inaccuracies or stigma is stemming from a number of factors. One is it's only as good as its training data. So the biased training data, we know is one of the primary risks. For example, if the training data predominantly includes mental health experiences of white, educated, higher socioeconomic status individuals, the LLM may struggle to be accurate or relevant or understand and appropriately respond to the needs of a more diverse population. We know that those kind of limitations in data exist in our research as well. And so you could have the best intentions of training an LLM to deliver evidence-based treatment, but if you are pulling from studies and evidence that is limited in the population that was included in the sample, you can further unintentionally amplify that inequity. And so ensuring there are methods and techniques you can use to include and ensure that your sample, the training data that you're using is appropriate, can also amplify stigma. So we've talked about the base model, even of whether it's ChatGPT, Gemini, et cetera, it's trained on the internet. And it has some of the same cultural biases. And unless you follow specific techniques to mitigate that and identify it, it could unintentionally perpetuate stereotypes, inaccurate information.
Yeah, no,
in its approach.
And I'm sure we'll get better training sets with time. And again, as you said, we're building these specialized medical ones that will hopefully minimize those as well too. And one interesting thing you and the team put in the paper, you said there's a need for additional standards of ethical professional conduct that should apply when LLMs are engaged in mental health service provision. So what is that? What are you envisioning that could look like, or what does that mean?
Yeah, so what we were thinking about is how do we, and something I've thought about even from kind of the early days of blended care models, of how do we adapt the principles of our ethical codes as healthcare professionals, whether it's a psychiatrist, psychologist in this context, how do we adapt the principles and the intention behind them to this kind of modern approach? And so what I mean here is boundaries of competence. So the LLM should operate within the boundary of its competence. They should only be used for mental health tasks, which they have been rigorously trained and tested and proven to perform well on. Should also have transparency about the limitations and clearly communicate the types of tasks for which they're appropriate or not suitable. Also, if an LLM encounters a task that is beyond its competence, it should ideally, this comes down to how you're implementing it in a care setting, should withhold input. So that means don't answer the question. If you're not able to answer the question, refer, right? And so being able to train a model to do that, also informed consent. And there's a whole bunch of pieces within that, confidentiality and privacy, preventing over-reliance. We're talking a lot in our society about preventing over-reliance on technology or deferring to it too much or excessively using it. We think about trust and the importance of how you build trust. And then, other pieces like transparency and explainability. So an LLM should ideally be able to explain how it got to its particular conclusion, and be transparent. And so techniques like chain of thought reasoning can help reveal a model's reasoning approach or provide clear justifications. We think about this also as providing references or citations. So I'm recommending X, and here's the reference for that. So there's a number of methods that we can use to address some of these, but I do think we still need to be grounded in our ethical code.
Yeah, but you can't just say I'm using an LLM. I'm going to do whatever the LLM tells me, which sometimes that's what you see people wanting to do, which is a little bit worrisome, but I think we're quickly developing how to use these. And I think we've covered a little bit about kind of different risks of bias and inaccuracy, but one thing, whoever illustrated this paper did a wonderful job. And all of you have the link. It's just like beautiful figures to look at, but Figure 4 really highlights this interesting idea of where does the human fit in? I think the key one is the human always fits in. When I say where, it's kind of at what level, at what dose, at how much. And I think kind of human in the loop has become the word that maybe your team even set, Megan. But what are the different ways you see human involvement in these LLMs, understanding different use cases, different patients, same patients at different times, need different therapy, different medicines, they're going to need different LLMs and human support, but how do you see kind of the human in the loop?
So I see it exactly the same way that it should be in any digital approach to mental health. And so this is around conceptualization, defining the role that a large language model should play. Means like selecting the right use case for it, being involved in guiding the development, ensuring that appropriate consent procedures, privacy practices, the training data is representative, unbiased, evidence-based, making sure that you're feeding it back data to drive continuous quality improvement. Something that we do a lot of is testing. So red teaming, which is basically meaning you're doing those evaluations of, are the answers high quality? Are they accurate? Are they safe? Providing that feedback will help improve the quality of the model. And then deployment. So you could think about this as implementation. So, it's not sufficient to just build the technology. You also have to think about how you are putting it into the world, the safeguards around it, your ability to help ensure that the right people are kind of matched with it, prepared to use it, understand its limitations, and that there's kind of additional layers of support around it. And then evaluation, right? We need to make sure that once it's deployed, it's working, you're continuing to improve it, and that we are ideally transparently communicating kind of the competence of it, and ideally holding it up to benchmarks that exist in clinical practice.
Yeah, we do have benchmarks in psychology and psychiatry. They're not always the best, but we have them, and I would argue they're not horribly impossible to beat.
Right.
We have in it. And I think one broader question, a lot of people listening here are junior, they want to get started in the field, they see the potential. How do you suggest people even just keep up or learn about this? It's such a rapidly changing field. Like, where do people start to learn?
So I always say, start to use it yourself, but please not with your patient's data. So use these tools for things that are in your daily life, that are not high stakes, right? Just so that you can understand how, regardless of if it's ChatGPT or Gemini, just get familiar with it. Try to, I think we see a lot of people using Notebook LM right now for things that are, right? Like, I'll give you an example. I used upload this paper and make an op-ed style abstract for me, or help me, prepare talking points for a talk on AI and mental health, right? You can understand what it's good at and what it's bad at, just by using it in your kind of non-clinical life. The other is to read the literature. As there are review papers coming out. It would be even just trying to read some of the core methods papers, particularly about if you look at the safety literature on understanding some of those basics. You can also take courses. So there's a lot of courses that are available. We have one via Coursera on Grow with Google. We also on Google Cloud Skills Boost. We have an AI course specific for healthcare professionals. We have YouTube videos from credible sources. There are, not for free, but courses through, Harvard Medical School that even can give you continuing education credits. But I think it's reading, practicing, and then, really it's a lot of what we've done is experiment, try to use it to do different things and become familiar with the technology outside of your profession first, and then get up to speed on the specific methods that you would want to deploy. It also, just like as a clinician, we learn how to understand and unpack a study, right? We're not just taking a paper as truth. We're going first and reading the methods section. And so, it's like I still do the methods, then the results, and then, maybe I read the rest of it, but I kind of gotten what I need to. It's the same thing. You need to understand how it's made. And so focusing on what are the methods, again, would be my recommendation.
I think that's very strong advice to people. It's nice to have free resources to learn, and there are a lot of papers. Again, I think in some ways people should start with your paper, and that's why we're highlighting it, because it gives you such a good overview of what you can do in the space, what to think about beyond the classical, hallucinations is the word that gets used. I personally don't like that word, but there's more parts to fit it in, and there's really roles for a lot of people. You don't have to just be a coder. There's roles for designers. There's roles for just clinical implementation in this, ethics, regulation. It really is the birth of a brand new field. And how often in psychiatry and psychology, in just the mental health field, do we see a whole new space open up, where in essence that our field can go first, and in essence set the standard for it. So I think there are amazing opportunities in this field. I want to open up for a couple minutes of questions. We likely have too many to get to everyone's questions, but we'll maybe go for about 5 minutes and try to go with a couple broad questions. Also realizing, as a new and evolving field, a lot of things we're learning together, and I think that's why all of you are here. We hope that you'll carry on as become leaders in the space and develop some of the new answers. But one question someone's asking, as we're looking for more cultural customization, we're looking to train these to work in different populations. We said right now they're kind of trained on the big, let's just call them US or Western European data sets that like Reddit is a big data set, Wikipedia. How do we go about getting the data sets to train these for cultures or groups that may not have generated as much data on the internet? There's no single answer, but any hot takes on that one?
Yes, so there is no single answer, but I'd say best guiding principle is to do co-creation. So we think about this as like participatory research, but involving people from that community. So I'll give you an example to make it really concrete. So if we want to work on something we're focused on is how do we train non-clinicians to deliver evidence-based task sharing models in mental health. So we scale access to some level of mental health support in regions where there might be like 5 psychiatrists in the country. And so in that context, obviously there's not going to be training data, but we're going to need to go give a recording device to somebody to record a conversation. There are ways that you need to actually build the data. And so if it doesn't exist, one, you can certainly feed it things like books, novels, right? Anything that helps get a sense of the culture, but you may also need to go actually build the right data set depending on what you're trying to do. And then you take all those other steps into consideration around looking at that data and making sure that it is representative. But I would focus on partnering to generate the right data set that you want to fine tune your model off of. Because LLMs or generative AI is very good at using multimodal data, it's not as high of a barrier as it might have been previously, because you can take somebody's handwritten notes and transform that into text. You can record a conversation and transform that So some of those friction points have been made easier, but there's still a lot of work. And that's what we need to do, is actually foster much more collaboration in the mental health field to build better data sets that we can then have more high quality models trained on.
That makes sense as a ground level solution that will have benefits, not trying to kind of have a window dressing fix to it. And this next comment, I think, is from James Woolard, who's a leader in the NHS UK, but he's more saying, would the sound of or therapeutic use of silence be a marker of maturity of large language models, which is an interesting concept, right? Because these models like to say, of course I can help you, but here's 100 things to do. Any thoughts on the sound of therapeutic or silence as a marker of maturity?
Yes, I think you could. So that's an example of something that you could certainly train a model to do, especially as we see these models as kind of audio interactions, right? It's you're talking to it, it's talking back to you. It's not just kind of text-based interaction. So there are efforts underway to train models to be more compassionate, to have more empathy, to be validating. Certainly silence is an important part of that. We have decades of human computer interaction, UX research that has guided the way we've developed technology to understand humans and how we act. And so that we're designing tools that are, we feel like understand us and respond to us appropriately. And so there's a lot of kind of historical knowledge on that from broader like mirroring style. The one thing is right now we see, and this is a risk of LLMs, is they like to agree with you. But if I'm talking about, if I'm have, rumination, do I want the LLM to agree with me? Maybe not. If I am perseverating and talking and, talking about trauma, do I want to? So there are things that make sense in a general purpose LLM that are risky. And so, but yes, there's a number of things that to train a model to either train a therapist to be effective, they would need to teach it.
Yeah, that makes sense. It's a humorous example. I was playing with Notebook LM and put an abstract to a grant in, and it made this podcast about the grant. It's like, this is the greatest idea ever. Like, whoever wrote this is brilliant. And I was like, oh, it's actually not that good. So sometimes it's funny how it agrees with you, but sometimes when you hear your own thoughts back, you go, ooh, not there. But a serious question from Ricardo Munoz, I think another expert from the Bay Area in the field, is saying, what do you think the potential is for digital, for kind of helping self-help based interventions? We know the engagement is hard with self-help tools. We know there's amazing potential. Do you see a combination of these LLMs kind of coming back and making these self-help tools super or turbocharged? And that may be the last question we have time for. So
Yes, Ricardo, wonderful to have you here. Someone I've learned a lot from over the years. Yes, absolutely. I think that's been the vision of many of us for a long time. And often it's adapting them to culture, language, learning style, personal preference, making them engaging, right? Especially as we get further closer to the prevention end of the spectrum, it still feels like work. And so how can we, the way that we're thinking about it is, what is that next thing that I need to, how do we make things really simple, lightweight, and yes, absolutely. I think that that's an appropriate place for us to use the kind of chatbot interaction, right? But also be able to just layer in this to existing approaches. So I think that's a great opportunity.
it makes sense to they have to fuse because we have wonderful tools out there, and if we can solve engagement. That's what behavioral health does. We help people do things that can be challenging. So I want to break there. Thank you so much, Dr. Bell. We covered a lot of ground. We put the paper into chat. I think it should be required reading for everyone. Dr. Bell is usually a decade ahead of all of us, so it's nice to get a preview of what will be happening for the future. I'll close in saying we do have a symposium with JMIR and SODP, Transforming Digital Mental Health. It's going to be on December 11th at 11 a.m. Eastern Time. For those of you from Australia or around there, we've already got notice we may make a second symposium that will be in Australian time because there's so much great work happening across the world. But for now, I want to thank Dr. Bell, thank everyone for listening. Until next time, bye.